Welcome to the last webinar for the We Choose Health Baby Friendly project. I am glad you all were able to join us today. My name is Beth Seidel and I'm a consultant manager with the Illinois chapter of the American Academy of Pediatrics for this project. For the last 18 months, ICAP has been providing technical assistance to 15 hospitals and their supporting health departments as the hospitals have pursued baby friendly designation. The communities participating in this project have made great progress towards baby friendly, and I would like to thank everyone I have worked with for giving me the opportunity to be a part of your journey. It has been a great experience for me, and I am so encouraged by all the work that is now being done throughout our state to improve breastfeeding support for families in Illinois. I am really excited about this webinar today, as we will have the chance to hear from Dr. Federici, who has successfully established a breastfeeding-friendly medical practice. I am looking forward to learning from her experience as we all strive to develop not only hospitals, but also communities that are baby-friendly. I'm going to hand things over to Billy Kalb from ICAP now, and he will go over the logistics of participation in today's webinar and how to ask questions at the end.
Thank you, Beth. Good afternoon, everyone. My name is Billy Kalb from ICAP. I'm just going to tell you a little bit about how we're going to do questions today. Please hold all of your questions until the end of the presentation. Dr. Federici will let you know when we're ready for questions. And then how we're going to handle questions today is I'm going to invite you to enter all of your questions as text through the questions function of the GoToWebinar control panel on your screen. Once we do that, we can pass the questions over to Dr. Federici for her to address. So without further ado, with that out of the way, I'm going to turn things over to Mary Elsner.
Welcome everybody today. My name is Mary Elsner. I'm the director of the We Choose Health Baby Friendly Hospital Project at the Illinois chapter American Academy of Pediatrics. I want to take a moment to recognize Beth Seidel, the manager of the project, for all her hard work and the technical expertise she has provided to health departments and hospitals participating in the project. And thank you all for all your hard work to make this project successful and for making your community baby friendly. We are very fortunate today to have as our guest speaker Dr. Karen Federici. Dr. Federici is a board certified family physician with a solo practice in Genoa, Illinois, where she has been practicing for the past 8 years. She focuses on the care of women and children and subspecializes in breastfeeding medicine. Dr. Federici is a board-certified lactation consultant and a fellow of the Academy of Breastfeeding Medicine. Welcome, Dr. Federici.
Thank you, Mary. Thank you, everyone, for joining me today, and I hope that I am able to give you information that will help you to make your practice more baby-friendly. So as we get started, these are the things that I'm going to cover in today's webinar. We're going to talk about what baby-friendly is in a primary care office, why it matters to us, what's in it for us, and how we can fit it into our practices because we are all busy. And then once we're doing this, how can we get paid for doing so? And how can we as a lactation and breastfeeding community work together? So we'll start off talking about what a baby-friendly practice means. Baby-friendly has to start with breastfeeding friendly. That will be the key component. And according to the Academy of Breastfeeding Medicine, they have a clinical protocol addressing breastfeeding-friendly physician offices, and they state that it's a physician's practice that enthusiastically promotes and supports breastfeeding through the combination of a conducive office environment and education of healthcare professionals, office staff, and families. So we have to have the correct environment, and we have to give the education. And why is this important? Well, we're all involved, hopefully, in baby-friendly initiation in our hospitals, but it's not just for hospitals because we all want to give an optimal level of care for infants, and this includes our offices. We know that breastfeeding is the normal way for human infants to be fed, so of course we have to be breastfeeding friendly. Breastfeeding is always best practice, and in fact, it's the standard of care. Breastfeeding leads to healthy patients in our practices, and we owe it to our patients and their parents to be up to date on the infant health and nutrition. And we know that breastfeeding is important to parents. They've all heard over all these years that breastfeeding is better for their babies. So they know that this is what they want for their baby, and they want, need, and deserve our support, active support. So most of us probably feel that of course we're baby friendly, of course we're breastfeeding friendly. But merely saying, oh, how wonderful that you're breastfeeding, or yes, breastfeeding is best for your baby, isn't enough. And unfortunately, as physicians, at least when I went through medical school and residency, there was very little education about breastfeeding. Some of that is changing. The AAP has come up with a breastfeeding curriculum for residencies that some residency programs are implementing, but I don't think that it's as prevalent yet in OB-GYN residencies. Family medicine, I believe, is following suit with the AAP, but we still have a long way to go because most of us are not currently in training. We've already been there, and we have missed out on this, what I call black hole. At least in my training, my only introduction to breastfeeding was rounding once or twice with a lactation consultant. So, and as physicians, we don't like things that we don't know. When we don't have an answer to give people because we don't know the answer, we're uncomfortable with that. The other thing that makes us uncomfortable is that we cannot measure intake. Breastfed babies, how much are they getting? There's no gauge on the breast to say baby took in X milliliters or X ounces. So that makes us uncomfortable. And it makes parents uncomfortable. And if we're uncomfortable and they're uncomfortable, then we're not going to do a good job reassuring them that the baby's intake is what it should be. So we have to learn how to gauge this without having an actual gauge on the breast so that we can reassure parents who are new and have questions. Also, as physicians, I think we've all had the feeling that we don't want to make mothers feel guilty. But we know that it's our job to tell parents when they're doing something that is risky for their infant's health. And there's plenty of evidence to show that formula feeding does have health risks for babies. So we're not doing our families service if we don't give them the risks. Just like we tell them the risks of co-sleeping, we tell them the risks of not using a car seat, we tell them the risks of smoking around their children. We also must tell them the risks of formula feeding. So we need to get over this. We'll make them feel guilty. And then oftentimes we actually think we're helping if we tell a mother to go ahead and supplement. She has concerns that the baby's not getting enough, the baby's fussy, the baby's not sleeping. We think we're actually going to help her by just having her give a bottle. But we're actually interfering with the physiologic process of lactation and breastfeeding. And we'll go over all the ways to get over these issues. So the bottom line for a baby-friendly office is we need to give parents accurate and up-to-date information and let them make an informed decision, the same as we'll do in the hospital with them. The staff gives parents all the information that they need to make that informed decision. And we have to truly believe that parents have the right to have physicians who will wholeheartedly support them in their choice to breastfeed, and that the infants have the right to be breastfed. So support goes way beyond lip service. How will this benefit your medical practice? I can tell you from personal experience that you will have parents and patients who are happy, grateful, and extremely loyal to you and your practice. You're going to have healthy patients. So while you might have more time-intensive visits in the early days, you will have many less visits for illness along the way. It's also very personally rewarding. We as physicians are very altruistic, and we think we like to do things just because it's the right thing to do, but it sure does feel good when you see how much you can truly help someone. And then you have the marketing opportunity of saying, we're a baby-friendly practice. And because so many of our patients and parents look on our websites, they hear through word of mouth, that baby-friendly term is going to become quite a buzzword among parents. And if you can say, we're a baby-friendly practice, you will draw families to your practice. Again, I can tell you from personal experience that mothers will do your marketing for you. Word of mouth is the way my practice has grown over all these years, and I'll show you in a minute how much it's grown. And lactation consultants would be thrilled to have more physicians to steer their patients towards, to say that this doctor is truly breastfeeding friendly. You should go see this doctor. On this map, I've plotted my patient visits from the last 12 months. My office is here in Genoa. Okay, it's a very small town here in northern Illinois. Most of my patients come from about a 20-mile radius in the towns nearby. But if you look at these dots all over this map, I have patients coming from more than a 50-mile radius. If you go across and up and down, it's probably more like 80 miles. So you can see how much of a need there is for physicians who are breastfeeding friendly. Some of these are breastfeeding consults, so they come once or twice for their breastfeeding problems, but many of them are not. I have a large number of primary care patients in the Rockford area and a great number in the western suburbs here of the Chicago area. I'm in a very small town. Most people in the suburbs wouldn't think of driving west to a small town to go to see a doctor for their child. And, you know, they're going to go to another suburb. So you can see how much of a need there is. I'm happy, I would be thrilled if there were more doctors in my general vicinity that parents felt were baby-friendly and breastfeeding friendly. The need is out there. Be that doctor fulfilling that need. And within your own staff, this is my nurse, Jennifer, nursing her youngest child, Logan, when he was a baby. At the time Logan was an infant, I had 2 staff members who had babies, and both of them brought them to work, nursed during the day. We had one little room set up with as the nursery, if you will, so we had packing place for them to sleep, a room to go in and pump or nurse, and they brought their babies to work. But then they weren't absent. They were at work. We would all take turns holding a baby who needed to be held. Babies aren't sick, so you don't have your employees missing work because their children are sick, and you're setting a wonderful example for your patients and the community around you. I informally surveyed our local Facebook group for breastfeeding moms. And this is a mom-run group, so it's not even a hospital or our lactation center-run breastfeeding group. This is a mom-run group. And I posed some questions to these moms about what, in their opinion, made a medical practice breastfeeding friendly, how important it was to them, and what were some of their experiences. Excuse me. And this is what they told me. I feel breastfeeding is the #1 influence and choice for a physician. It's the foundation which a majority of other health-related decisions are based upon. I mean, how true is that? Breastfeeding friendly is my #1 priority. Thankfully, we found a practice with a lactation consultant. It's a huge priority for me after being with a physician's office. That's it. Excuse me. We thought about going somewhere closer to home, but we make the further drive because if we run into problems, we're supported. And as we go along, I'll have more quotes from the same Facebook group on moms and what they told me. Okay. What does a baby-friendly practice look like? Again, it's a breastfeeding-friendly practice. So the silent messages that you give in your office are very important. We need signs to tell moms, this is a safe place to breastfeed. This is a place where breastfeed is not only supported but encouraged and celebrated. You can post pictures all over your office of nursing moms. Nursing moms love to have pictures, give you pictures of themselves. You can have signs like this, the international symbol for breastfeeding, breastfeeding welcome here, pamphlets with information about breastfeeding, all of those things. And at the same time, you need to eliminate all of the freebies that you've gotten over the years from formula companies. These send the wrong message to our breastfeeding moms. And just like in the hospital, as part of the Baby Friendly Initiative, one of the 10 steps says that we're not giving out any formula company products, the Ban the Bags campaign. You need to also get rid of those things in your office and not give them out to breastfeeding moms. Formula companies purposefully market towards breastfeeding moms. They already have the formula feeding moms. They don't need to market to them. They need to market to our breastfeeding moms, so that in that moment when she's unsure whether the baby's had enough, she's going to give that bottle, and one bottle interferes with breastfeeding more than most people think it would. Formula companies know that, so you need to just get rid of those things. And then it's your actions, not just the signs, but the actions. I'll show you some quotes from moms about how important it is that your staff is involved. In my office, my front desk staff, if they see a mom that's either struggling because she's trying to put up her nursing cover and get the baby latched, the receptionist will say, would you like to go into a room? And if we have a room available, then we escort them back. Otherwise, just a chair in the back hallway so that they're not in the waiting room and they feel a little more comfortable if they want privacy. Moms really appreciate that. In each exam room, we have a nursing pillow. So here's one of my moms, and it's hard to see this baby because she's all in this hoodie, but she's got a nursing pillow there. They're available for the moms to use. At every visit, we have the washable covers. We just wash it between visits. Moms want to be encouraged to breastfeed if they need to during the visit, and that includes during procedures. So in the hospital with Baby Friendly, we're going towards let's do the PKU while mom is nursing. The same thing can be done in the office. When moms are nursing, we give you immunizations. Just grab the legs, give the immunizations while baby's still nursing. Heel sticks are even easier. It's pretty easy to grab a foot and do what needs to be done. And that makes mom feel more comfortable, baby's more comfortable, because it's stressful for both of them when the baby has to have anything painful done. And if we can ease that procedure, moms are eternally grateful. Again, we allow the moms to stay in the room after the visit as long as they need to. And moms commented on that. I can stay as a nurse as long as I need to. With my first, I felt a lot of pressure to have her fed for the appointment, get her out before she started crying for more. So she didn't feel in that particular office practice that she could comfortably nurse, relax, and make sure her child was content before they left. We've been encouraged to stay in the room as long as we can need it. As long as we need after appointments, relaxed attitude makes a difference. Books and toys in the room for the other kids. And again, these are moms just on the breastfeeding group. Some of them are my patients and many of them are other people's patients. But this is what they have to say. So how can you do this in your practice? What should you do in your practice? All of your staff should be able to assist with basic breastfeeding triage calls. So this takes time, but all it takes is one champion in your office to work with everyone else on what do I say when. And really, if they're just encouraging, they don't have to have the answers. They can say, oh, well, Dr. So-and-so will talk to you about that, or the lactation consultant will talk to you about that. But how wonderful that you're nursing. Oh, your baby looks beautiful. Oh, he's getting so big. All those wonderful things that moms want to hear about their babies. And mothers should be encouraged to breastfeed during the visit, because that's the best way to learn what normal breastfeeding looks like. It's the best way for your staff to be comfortable with nursing moms is if everyone around them is nursing their baby, they will get a lot more comfortable with seeing the baby nurse, seeing breasts, etc. And just like everything else in medicine, if we recognize normal, then it's much easier to spot when there's a problem. So if you see baby after baby who's not having any problems, mom's not expressing any breastfeeding difficulties, she's just normally breastfeeding her baby, you get to recognize what a normal latch looks like, what good milk transfer looks like, and that way when there's a problem, it's easier to say, oh wait, something about this doesn't look right. Not all of your staff have to be lactation consultants or any such thing. They just have to be comfortable with breastfeeding and supportive and able to answer basic questions. And if you have your staff trained, then they can go in when they're rooming a patient. Here's somebody in my office, mom's nursing. We can check the vitals. We can listen to the heart rate. We can check the respiratory rate. We can get the temperature, all while the baby's latched on. And in the meantime, we're observing the latch and saying, Mom, how's breastfeeding going? And if she has questions that we can answer, great. Otherwise, okay, I appreciate those questions. We'll get somebody that can answer those. And then in my office, once I leave the room, I'll often send somebody back in and say, she has more questions about this. Can you give her this handout, or can you go explain X, Y, or Z to the mom? And it works really well. And so then you also need a support network and resources that includes your practice, but includes local lactation consultants, community groups, so that you have other resources for a mom to get breastfeeding help. And what do mothers expect from us? The most important things are giving them accurate information and then support, support, support. They want praise, encouragement for what they're doing. So here's again what some of the moms that I've polled said. So what do they expect? That you won't just say, give formula if the baby's weight gain is a little slow. Figure out what the problem is instead of trying to put a Band-Aid on it. Lactation nurse offered tips when I was struggling. If not struggling, just asking about my child. This is a struggle, the frustration of many moms, told to put on formula. They want to feel at ease. They want to not feel inferior and powerless and feel respected for their decisions. So what should we provide? Again, it's train all of your staff. Here's a comment again, receptionists who are breastfeeding friendly and knowledgeable. First people I encounter when walking into the office are receptionists. If baby's fussing, they don't hesitate to make you feel comfortable nursing in the waiting room. Again, encouragement, reassurance, praise, small talk about how big baby's getting, support for me despite low supply. It was never all or nothing. They celebrated every drop and made me feel successful. And then a triage system. So just like you would have a triage system for any other reason that parents call, you should have appropriate triage for breastfeeding. So this mom says, I appreciate that our doctor makes breastfeeding a priority. If we're having issues, the staff gets us right in so the problem's addressed before it becomes a major problem. So just as you'd have a parent call with concern about an ear infection, you wouldn't say, well, we can get you in for that next week. The same thing with breastfeeding issues. They cannot wait. They need to be addressed sooner rather than later. And if you can come up with your own triage tool for your office. Here's a great one put out by the Massachusetts Breastfeeding Coalition. It's available on the internet, and it makes your staff feel empowered that if they have a tool like this, they don't have to be experts in lactation. The questions and what to do are right here laid out for them. And you can see that as we go through the questions, you're essentially going to fall into the need to be seen today or wait 1 to 2 days. There's nothing on here that says next week. And you can take something like this and modify it to fit your practice. But I highly encourage you to do this. Again, that it puts all of your staff on the same page. They're all giving the same message. In the office, what should we provide still? A nice conducive environment. So we have nursing pillows, as I said. We have some recliners in the office. You can get kinds that can be easily wiped off. But even just a more comfortable chair than your standard armchair is really appreciated by breastfeeding moms. Something I see all too often when patients have been at other physicians' offices is that infants are weighed with their clothes on, with the diaper on. We're not doing it justice to the weight if we don't get an accurate weight. So the baby should really be naked, because how do you judge from one visit to the next what the accurate weight gain is if you're not accurately weighing the baby naked? And then plotting those weights on a World Health Organization growth chart is the other key. I think most people are probably doing this. Even my EMR system changed over to the WHO growth charts a few years back. But if you have an EMR system, check to see what growth charts they use. And if you're still using paper, then check to see that you're using the World Health Organization growth charts, not the CDC ones. And all the recommendations by the AEP and the CDC do say to use the WHO growth charts. And the reason is because those are based on breastfed babies. And we know that breastfed babies grow at a different rate than formula-fed babies. So again, you're not going to be accurately monitoring their growth if you're using the wrong growth charts. You know, and here, this, I can't tell you how important this is. Give evidence-based information and guidance. The longer we're in practice, we tend to say what we've always said about things. But I think most of us pride ourselves on at least trying to keep up with what's current. Well, you need to keep up with what's current on breastfeeding too. And so what you're telling moms should be, you should make sure that it is accurate. And we should be able to tell them basic things. Messages that they're getting in the hospital, we should be continuing in the office. So if they're asking about pacifiers, explain. You can't just say, oh, no, that's not recommended for the first month. We need to explain why. Explain how we're developing that milk supply in the first month. Milk supply is all about, or successful breastfeeding is about supply and demand. So if we use a pacifier, we can interfere with that. And again, the staff can answer these questions for you too, but we need to give them the information to do so. And if moms are using supplementation that's not medically needed, then we need to explain why that's not a good idea. A common scenario that I get is the dad wants to give a bottle in the middle of the night, and so I have to explain why that isn't such a great idea. Even if mom is pumping and giving breast milk in a bottle, I explain that, Dad, I know you want to save her, you want her to get more rest and you want to feed the baby, but she's still going to have to get up and pump at that time that you're giving the bottle, so you're not saving her any work and making more work, as a matter of fact, because then you have to clean the pump parts in the bottle, and instead support her in other ways. Get the baby, bring the baby to her, change the baby, all those other things you can do to help so that she can stay relaxed while she has to feed in the middle of the night. And so then and then again, if they're giving formula, then you're explaining that that's going to affect her milk supply because she's missing out on that feeding, and nighttime feedings we know are the most important in establishing a good milk supply. So while it takes time to answer each of these questions, you're educating them and they go out and educate other people. And make sure you're following the AAP breastfeeding policy. So you're encouraging at least 6 months of exclusive breastfeeding, and you're not advising parents to introduce other foods until at least 6 months unless there's a specific reason to do so. The other way we can help parents, and that we should be doing in our office, is setting realistic expectations. So some of these handouts are from the Illinois Department of Human Services, and they have really good handouts that show what the actual size of the baby's stomach is on the first few days. So parents have a visual representation of how much their baby should be eating, that it is a very small amount. When they have an image of a bottle in their minds, then they are not getting that, they have unrealistic expectations of how much milk they should be producing. This is a great one all these come in English and Spanish, but this is something that you can give in your office that answers those basic questions, that says how much is the baby eating without measuring it, without putting it in a bottle. And just show moms, do you have enough milk? Here, if your baby's output is good, then you know that your baby is getting enough input. And all these go along with anticipatory guidance as well. So I always talk to parents about growth spurts so that they don't think, they go home, all of a sudden the baby's nursing more frequently, and their first thought is, I don't have enough milk. So they may or may not give a bottle, or they might call you. But instead, if you tell them what will happen during a growth spurt, then they will be ready for that and say, oh, this is a growth spurt. I know what to do. I just nurse more frequently. Same with stool pattern changes. You can avoid those phone calls. My baby's constipated, because we know breastfed babies will spread out their stools. After about a month or so, they start going much less frequently. So if we tell them that ahead of time, then we give them we empower them that they understand what's happening with their baby without thinking something's wrong. Answers to the common questions of, I don't have enough milk, my baby isn't sleeping, how do I know my baby's getting enough? All these things will help give you tools to answer those questions. And again, if your staff goes through these, they start to know what to say to the patient so they can answer a lot of the questions on the phone or for you in the office. And above all, reassure, reassure, reassure. There's not always something wrong, so it's fine to say, that's normal. It's normal that your baby's waking up frequently. Your baby needs to eat frequently. Reassure, reassure, reassure. In my office, one way that we reassure parents and also reassure me is that baby's intake is good is by doing test weights. So for any baby 2 months and younger in my office, or anybody that comes in with any breastfeeding problem, or any baby that we're following over months for their weight gain, when the baby is weighed by my staff member, the baby will be weighed naked and then weighed with a clean diaper. Then parents are told that they need to leave that clean diaper on the baby. We have the visit, mom breastfeeds during the visit, and then we reweigh the baby. So we're marking down in grams how much the baby weighs. Initially, that's just what the weight is now. But then what really counts is with that clean diaper on. What is the weight in grams? And then after the feeding, what is the weight in grams? Then we could calculate the transfer. So how much did the baby take in? With the conversion being about 28 grams to an ounce. So baby takes in 56 grams, we say, wow, your baby's just ate 2 ounces. And they love hearing that. They love hearing it. And if it's low, then we know, okay, even though that baby is nursing, 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 and we might think that they're doing really well, they're really not transferring much milk, so let's figure out why. So this is something that anybody can do in their office, test weights. Lactation consultants do it all the time, but we can also do it. We're weighing the babies anyway, so we just weigh them one more time. And then we see after the feeding about what they're taking in. Again, still going through what we need to be providing in our offices. Okay, so you get a breastfeeding problem or a baby that's not gaining well. Instead of giving formula as your first resort, it should really be your last resort. Do I have parents supplement with formula? Absolutely. How often? Very rarely. Because if we need to supplement, most of the time, most breastfeeding problems are not maternal problems. They're stemming from the infant and how well they're nursing. Sometimes it's a maternal problem, but those are the exception. So in most situations when I assess and it's the way the baby's nursing or there's just poor milk transfer, we can have moms pump and give that milk in a bottle or in a cup or any other way, but we're supplementing with mom's own milk first. So again, formula is a last resort and should be. We need to be able to provide accurate information to our patients and parents about maternal health. So even in my practice where most of my moms are breastfeeding moms, I still will frequently get that call from a new mom that says, I'm breastfeeding and I have a cold, or I have a stomach flu, or I have the flu, whatever I have, and is it okay to continue to breastfeed? And then that's a perfect opportunity to explain how beneficial it is for that mom to be breastfeeding at the time where she's sick because she's giving the antibodies to her baby and preventing her baby from getting that virus or whatever the mom has. And the same thing with medication, or mom needs surgery, or mom needs a radiology procedure, to educate and give accurate information about can she continue to breastfeed. And at the same time to tell her that in any of these situations that we are the ones she should be calling if she gets an answer that she doesn't like pump and dump for 48 hours because you're going to be having a test done, or here's an antibiotic for your urinary tract infection, but you won't be able to breastfeed, so just pump and dump for the next week. People that are telling moms this they believe they're being helpful, they're being cautious, they're protecting the baby, but if you've ever breastfed, you know that pumping and dumping for a week is much easier said than done. So you as the primary care doctor need to be the person that can accurately answer those questions. And later on in the presentation, we're going to go through resources for you to accurately answer those questions. Okay, we need to collaborate with other lactation professionals in the area. You don't have to do everything. There's other people that are good at this, so let's let them help us. We'll go through that again in detail as well. And make specific follow-up plans for breastfeeding problems, just as you would for any other medical problem. Whatever you're treating or seeing that's a problem in your office, you always give a follow-up plan, even if it's just wait and see and we'll recheck in X amount of time. There needs to be a follow-up plan. The same thing with breastfeeding. Come up with a plan, discuss it with the mother, refer if needed, but short-term follow-up in breastfeeding is almost always the key. When I get a problem in, so even if they're coming in just for a normal checkup and I see a problem, then I will frequently see them back the next day or in 2 days, or someone will see them, a lactation consultant, somebody will see them in short term. These cannot wait. Other thing moms tell me, that we should be recognizing other things as normal within breastfeeding, extended breastfeeding being one of them. Breastfeeding doesn't necessarily end just because this baby had a birthday. So here's the same mom that we saw earlier nursing her newborn on the pillow. This is her toddler who is also nursing. So extended breastfeeding for toddlers, tandem nursing, these are normal. We can't just assume that the baby, because the baby has a birthday, that the mom's going to wean. If they continue to breastfeed, we celebrate that. There's benefits. I had a mother recently in my office with a 2-year-old who has been diagnosed on the autism spectrum. And this is her 3rd child. And she came in just for a checkup, but she had recently seen his neurobehavioral specialist. And this physician told her that she needed to wean him, that there was no benefit to breast milk for him at 2. And she's an ordinary woman, not overly educated, just a mom. And she said, he really shocked me because I said, well, do you mean that there's just water in my breast now? There's nothing else in there? And she ignored that advice and wanted my opinion. And of course, there's still nutrition and benefits to breastfeeding at any age. So a physician telling her there's no benefit and there's nothing in there, there's no nutrition, nothing for your 2-year-old, is just inaccurate information. So don't fall into that category. These are, again, mom quotes about this, encouraging of nursing beyond a year. And plenty of moms are ready to wean at 1, and that's fine. We support them in that. But if they're not, that's great too. I'm going to put in one little plug here for tongue tie, because I think it would be a great benefit to breastfeeding families if we have more physicians that are recognizing and treating tongue tie. Now, everybody can pick out this baby that's very clearly tongue-tied, and this is a before and after picture from the Stanford website that shows the baby before the frenotomy, which is just a clipping of that lingual frenulum right there into the tongue, and afterwards. So you can see, here's that baby with the cupped tongue, and there's an indentation here in the tip of the tongue, and afterwards we have much better elevation of the tongue. So most of us all recognize that this kind of a tongue tie, when this kind of a tongue tie exists. But it's not always so clear cut. So and once you recognize it, you also have to recognize that it can most certainly cause breastfeeding difficulties. Does it always? No. But most of the time it will, even if it's not in the early days with mom having nipple pain or baby unable to latch. It can be with affecting milk supply down the road in a few months. So there are definitely benefits to releasing this baby's tongue. But there are also a large number of babies that have what we call a posterior tongue tie. And it's not so easy to see because you won't see this thin frenulum right there going almost to the tip of the tongue. These babies look more like this. The tip of the tongue doesn't really lift up off the gums very well. It's tied down, and you see the cupping. And this is Dr. can't think of his name, Jim Murphy, showing something that he came up with. If you press under those babies' tongues, if you press back into the, you will feel, if you feel under the tongue, you will feel a thick frenulum further back on these babies, and if you press into it, you can see that there's my mouse, the indentation of the tongue where that frenulum is pulling it down. So these babies are often the ones that are missed, and the only symptom will be mom's pain, or they're the babies that just cannot maintain their latch well. In my office, I do frenotomies, and it's a simple procedure. And the first time that you see it done, when you see the difference, when the mom tells you spontaneously how much better it feels, or how, oh, I can feel tugging. She didn't know that she was supposed to feel tugging with nursing. She immediately feels the difference. You'll appreciate the benefits of releasing tongues for these babies. And again, it's a simple procedure. So you can do it in the hospital, you can do it in your office, and it's back to the old, you know, what we did in medical school or residency. See one, do one, teach one. It's, if you see it once, you can easily do it, and then you can teach someone else to do it. The posterior ones took me time and take time to learn to recognize and then also to treat. So that this is not about tongue tie today, but I think it's such an important issue, and lactation consultants struggle to find doctors who will do this. And unfortunately, some of the doctors that do are specialists, and they make the procedure a little more than it needs to be. I've had babies in my office that have had tongue ties released by other physicians where there was all kinds of cautery under the tongue, and everything is burned, and that baby won't latch because they're in pain. With the simple frenotomy, they do really well. They go right to the breast afterwards. Again, and anybody can contact me about this. I'm more than happy to help. The AAP has this poster. This is just the words from it, but you can get the poster, 10 steps to support parents' choice to breastfeed their baby. You can post this in their office. This practice enthusiastically supports parents' plans to breastfeed their baby, etc. And it goes through the 10 steps that we should be incorporating in our office. Make a commitment. Train your staff. Tell everybody, early follow-up, breastfeed on demand, maintain lactation, anticipatory guidance, accurate information about maternal issues, communicate, and expand your network. So we're going to go through a little bit more of that. But first, tell me I'm preaching to the choir and you're already doing all these wonderful things in your office. Are you getting paid to do it? We can be. So I'm going to give you a few strategies for how you can provide lactation services in your office, and then how you can charge for those. Okay, so first is find your office champion. Hopefully there's at least one physician and somebody on the staff that will be the champions, that will be the go-to person to send the breastfeeding problems to, and that will train the other staff members. Again, all staff assist with basic triage. If you have a staff member interested, consider getting them a CLC certification. That's Certified Lactation Counselor, or any other certification program, but get them some official training. I believe that every breastfeeding baby should be observed nursing for at least the first 1 to 2 months, and then only if needed. But mom might tell you, oh, everything's fine, oh yeah, no problems. But when you see that baby breastfeed, you see, okay, something's not right here. So just observing, even if it's just while you're talking to the mom, while you're asking about milestones, etc., watch her nurse and see what's going on. This is something that every larger practice should consider, hiring at least a part-time lactation consultant, or take one of your mid-level providers with interest or experience and get them some extra training, and then they can be the go-to person to provide the breastfeeding support in the office. And then once you're doing that, you can consider taking referrals or consultations from outside your office. I see patients all the time just in consultation for breastfeeding problems, and then I send them back to their regular doctor. And structuring it from a billing standpoint, you can do it a few different ways. So if you have a whole practice of people that are gung-ho about this, then everybody can work with their own patients and charge for it. If you have a large practice and you want to have just a specific or have a lactation consultant to do all of these visits, then that person can get their own NPI number as a licensed provider and see all the breastfeeding patients, and then you just bill incident to the physician. Or, again, have a mid-level provider, that a nurse practitioner, nurse midwife, a PA who specializes in lactation, and then all the patients in the practice that need assistance are referred to her, and billing is based on that mid-level. In my practice, these are the things that we do. All newborns are seen within 3 days of birth, unless they're being seen in we have an outpatient lactation clinic. So if they're being seen there and there's no problems, then I can wait 5 to 7 days to see the newborn. But at least somebody is seeing them within the first 3 days of birth. I have a nurse who is also a lactation consultant who works part-time. So on the days that she's in the office, then she will see all the breastfeeding babies and assist them, and then I still see them as well so that we can bill for my time. But she does a bulk of a large portion of the work for me. When she's not there, then my medical assistants will do some, but then I do most of the breastfeeding assistance. For lactation-specific visits, so they come in for a breastfeeding problem, we bill for a problem-based code for both mother and baby if it's applicable. Now, if a baby comes in just for a tongue tie, then oftentimes we'll bill for the baby. But when somebody calls for a consultation, we schedule both mom and baby automatically. And then if they come in and it's truly just a maternal problem, she has mastitis, baby's fine, everything else is going fine, baby's tongue-tied, everything else is going fine, then we will just bill appropriately for one or the other. But most of the time, because it's a dyad, both mom and baby are involved somehow, so we will bill for both. And the level of complexity, again, is based on how much is attributable to mother versus how much is attributable to baby. If I see them for, it's just a regular 1 week well visit or 2 week well visit or whatever age, I can bill for both the preventative visit and the problem-based visit. So you use a 2-5 modifier on the primary visit, which is the preventative, and then you bill and whatever level 99212, 213, 214 for the problem as appropriate, with the diagnosis code for whatever the problem is. The same as if you get a child in for a well visit and, oh, by the way, they have a large abscess or something else that some other medical problem that's separate from the well visit that you address, you can bill for that as well on the same visit. And then we schedule frequent follow-up visits, as I said. So they come in for a checkup, we find a problem with weight gain or something else. We will see them back the next day or in 2 days to follow up on that. And sometimes it's just a weight check, and I tell the parents that it's just a weight check. If you come in and the weight gain is good, then that's not a charged visit. The nurse weighs you and you go on out the door. But if there's not an adequate weight gain, then I will see the patient and we will charge for that appropriately. So here's some examples in that few-day-old baby, that 3 to 5 day baby, coding for the well visit. If they're new or established, it's going to depend on that. And with the under 8 days old appropriate diagnosis code. And then, again, there has to be a significant separately identifiable service provided, but often there is, jaundice, weight loss, feeding difficulties, whatever the appropriate diagnosis is, and then you use the E&M code, again, based on new or established with a 2-5 modifier. And these problem-based visits can also be coded based on time. So sometimes I do bill a higher level of complexity if I spent an extended amount of time, and you can look up in any coding book what those amounts of time are based on, again, your established patient. And so it doesn't have to have multiple complexity with tests ordered and things that we think of if we were seeing them for other problem-based visits. Think of it as, you know, if you see somebody for maybe anxiety, depression, or behavioral issues for children, oftentimes those visits take longer, even though they're not necessarily medically complex. They take longer, so you bill based on time, because if more than half of your time is spent based on counseling, then you can bill on time. And if your billing people in your office have questions, they can always call us. And then I schedule short-term follow-up visits to readdress the problem if needed. In addition, so that baby came in for the first well check, then we're going to schedule them in 1 week for their well visit anyway, even if we're addressing problems in the meantime. All right, now say you have a newborn. Mom calls, baby was born yesterday, she can't get the baby to latch, baby's screaming, whatever the problem is, or she feels the baby's very jaundiced, whatever she calls about, we get them in the very same day, or, or the next day at the latest. Say we're walking out the door, then we put them in for the first visit of the next day. And if it's really an emergency, then obviously we're going to have to send them to the emergency room. But those people, we have to get in right away. And then again, you're going to code for that problem-based visit based on whether it's new or established. If you saw them in the hospital, then they're established. And you can still, once again, code on time. We follow up 1 to 2 days, and then schedule their well check on a separate day. All right, now when mom calls to schedule a concern about breastfeeding, so these aren't just when I see consultations, even if it's my own patients, if it sounds like it's a mother-baby problem, 2 patients, so say she says, I think my baby has thrush, and well, then we ask, okay, well, how do your nipples feel? And if we think that maybe she has thrush, either she can go see her own doctor, or we can get them both in. But if it's sore nipples, if she calls about sore nipples, then most of the time the baby's involved in that. We try to put both of them in. And again, I don't bill for both unless it's appropriate once I assess the problem, but we always tell them up front that we'll see both of you and treat both of you if needed. Because so then you have 2 patients, 2 charts, 2 copays, and you're sending out 2 bills. Follow-up is as needed, 1 or both. And if mom has another doctor, then you're going to communicate with her about what's going on. Okay. I just listed here some common ICD-9 codes that we use for breastfeeding medicine issues. These are the baby codes. I use this, feeding difficulties, pretty frequently. Weight loss, if it's appropriate. Sometimes just fussy baby. This is for tongue tie. And for mothers, I would say sore nipples is the most common, but sometimes it's more severe than just sore nipples. We see actual cracks. And delayed lactation if we think that she's actually having a milk production problem. And then there's always the V code for mom, supervision of lactation. This is the one that they usually use for getting their breast pump covered. But if she just wants a reassurance that everything's well, you can use that V code. And the challenges to this, because of course there are challenges, is number 1 is time. Breastfeeding management is very labor intensive. It truly is, but it is worth every minute. And you can help yourself by, if you see patients in the hospital, to make sure that they're getting a good start. Observe breastfeeding while they're still in the hospital, or have a protocol in place where when you know someone has given birth, have your staff calling them as soon as they've gotten home. How are things going? So that you bring them in sooner rather than a week later to find out that the baby's lost a lot of weight and things aren't going well. So follow up early enough, and the earlier you catch problems, the easier they'll be to solve. Phone triage, and then smart scheduling. So my staff knows that these can take a long time. So they might schedule a big block of time for a breastfeeding concern, or if the baby's coming in for a well check, but we know we've been following them for breastfeeding concerns, they might schedule more time. And in between that, maybe something quick, like recheck ears or something that we know is quick. And that way, I'll go in, get started, and I'll step out while she's nursing because we have to wait for the nursing to happen so we can reweigh the baby. Meanwhile, I'll see someone else, and I go back in. So it's juggling your rooms, knowing how to place patients in rooms, and knowing how to put them on the schedule. And then again, utilize your staff. If you let them observe what you say to patients, or then they'll know what to say, and they can do some of this for you. So these are the ways to manage the time so that you can do it. The other challenge is that it's true, not all insurance companies or payers will reimburse you for both E&M services on the same day. But you can challenge those. You have your billing department challenge it. Send the documentation that you have full documentation that you did a complete checkup on the child, as well as a full assessment and treatment of a problem. And if it's time to renegotiate your contracts, address these issues. Again, do a lot of frenotomies, and I have some insurance companies that will give me try to deny claims. So if, say, I've done a frenotomy, then in a short time afterwards they come in for something else. It could be something completely unrelated. They will say, no, that's part of the global period, so we have to send in documentation. One has nothing to do with the other. But you have to be willing to challenge those, and when it's contract negotiation time, look at your contracts and see what they say. All right, the last thing I want to talk about real quick before we answer questions is coordinating care with the rest of the community. Because, again, I hope I've gotten the message across that the best thing that we can give our breastfeeding families is support. Support to do what they want to do anyway. And so we as healthcare providers here are on the left. And don't forget everybody. Don't forget about your local health department and your WIC professionals. You know, they're there to support breastfeeding as well. Outpatient lactation clinic, if you have one, is great. If you don't, work on starting one. All the nursing staff, try to all be on the same page. And you know, this side, we're all on this side, but this side is actually probably more important. This is who moms listen to. This is who moms ask for help before they come to us. Okay, so they're family members. So taking time to explain things to Dad, I often have to explain things to grandmas, and you know, and then they get it, and they say, oh, well, that's different than the way I did it, but they accept that things change. So spending time with the rest of the family is important. Peer counselors, if you have local peer counselors in your area, you're lucky, and utilize those. Mother-to-mother support groups. This is who moms talk to. You have local HLA groups and Breastfeeding USA. These are, again, trained mother-to-mother support personnel. And social media, we all know how that's where we find out everything these days, isn't it? So make sure you have a good network near you. You know, build one, work on building one. It's really worth it. Again, if you don't have an outpatient lactation clinic, start one. I've been in this area for 8 years, and we didn't have one, but I've been talking about it with our lactation consultant who's been here for a long time since I arrived, and we have one, and it's a great thing. And as a matter of fact, we need to expand because there's such a demand for these services. So, hey, your lactation consultant would love to have a champion in you to start one in your local hospital. Don't forget about private lactation consultants. They're out there, and they will come to the patient's home and help them. If you're not going to be that breastfeeding medicine champion, find somebody in your area who is, or at least, you know, the nearest one to you, so that if you do have a breastfeeding consult, you know where to send them. Find specialists who are breastfeeding friendly. This is, you know, pediatric specialists come in all shapes and sizes, as do primary care doctors. So when you send your patients to the GI doctor, the one that's always telling them that their baby's allergic to your milk, you'll have to switch. That's not the one to refer to. Find the one that recognizes the importance of supporting breastfeeding and finds other answers for these parents. The same thing, ENTs. You know, if you have an ENT that releases tongue ties, fantastic, but make sure that they're not doing more harm than good, because unfortunately, this is something that doesn't come up for them very often for infants in their training. They may have picked it up along the way. WIC, again, lots of, you know, depending on what your practice base, many of your patients might also go to WIC. So team up with them, support each other, help each other. And then again, the local support groups. Here's some moms all getting together, and this is what one of the moms said. I'd say community support is best. It's normalizing. So how can we best collaborate with each other? I mean, if we're going to do it, we should do it right. So let's be effective. We want to enhance the care we're providing, whether we're the lactation consultants, we're the doctor, we're the nurse, we're the HA league leader. We want to all work together, and we want to enhance and be collegial with each other. Unfortunately, too often, I mean, I hear things that I just don't feel are professional being said by people from all angles. And that doesn't help anyone. We have to remember that the mom and the baby are what's important. Our own personal feelings are not important. It's helping that mom and baby. So how we can all work together is the most important thing. How we can enhance what we're doing for each other and not hinder it. Now, are we always going to agree? No, but then let's talk about it. Let's share the resources. If you have somebody in your community that's giving outdated information, do everything you can to keep plugging them, even if you go through someone in their office, to keep plugging them into more updated information. And again, we're not always going to agree, but you don't want to just say, oh no, so the mom says so-and-so said this, and we say, oh, no, that's wrong. Don't say that. Say it nicer. Okay, well, we used to do it this way, and now currently we're thinking that this is a better way. Or, well, okay, he said this probably because of this, but I think this because of whatever your reason is. Give an explanation for why your opinion differs, because we just discredit ourselves and we discredit other professionals when we just contradict. We want to be respectful and professional about what we say. And then the other thing is, just like anything else in medicine, what patients tell us is what they heard, or it's just like the telephone game. It's not always exactly what was said, or they took something and interpreted it their own way. So if somebody says, well, Dr. So-and-so said, or the lactation consultant said, and we think it's completely wrong, maybe she misinterpreted it. So, it's always fine to go back to that person and clarify, what did you tell this person, and why? And then this is something everybody, we can't be afraid to be wrong, because we're all going to be wrong sometimes, and we can't be afraid to change our thinking on things, because we have to always continue to learn. In medicine, and if you look at the history of medicine, how many things have we done that we learned were not right over the years? It takes a long time to figure it out sometimes, but things will change. We can say one thing one year, and the next year we're changing what we say. So don't be afraid to be wrong, and learn from the people around you. Don't always have to agree. Just try to do it professionally. And as physicians, I think we have to remember that second opinions are welcome. Sometimes people want second opinions because they want to hear a certain answer, and we're not giving it to them, and that's fine. We're giving them what we think, but if someone else gives them the answer that they want, they're going to go with that. Right or wrong doesn't really matter. It's what the patient decides. So it's not a personal insult, and I do come across that as well, that if we have differing opinions, it has to be you're right, I'm wrong, but it doesn't. It's, again, because they're what? Opinions. So I always, if patients want second opinions on things, I'm happy for them to do that. I want them to get all the information, and maybe the other opinion will agree with you, and maybe it won't, but that's then ultimately they're up to them to decide whose opinion they were going to go with, or, okay, there's two people saying the same thing, so maybe it's correct. So, if people ask me who else they should talk to, I'm happy to give them someone else to talk to. And just like anything else in medicine, if a problem isn't outside of our scope or outside of our expertise, we have to refer. So it's just treat it like any other medical issue. Just find a good network so that you have someone to refer to. And locally, if we have colleagues that need extra education, they don't always want to hear from us. They're used to us. They're like, oh, there's that breastfeeding person, blah, blah, blah. So think about ways to bring in other speakers to your community, other physicians who are experts in this area that other doctors might listen to because they're a specialist from Stanford or from wherever. The Chicago Area Breastfeeding Coalition does a fantastic job. They've done this for several years now. They have an annual physician dinner seminar. So they have a physician speaker. They invite physicians and other providers to come to this, and it's about a breastfeeding topic. And then all the lactation professionals in the area talk to their doctors and say, hey, this doctor's coming. You probably want to go hear him or her speak. They have great information. And so every year that they've had this, the numbers of doctors that have attended have grown. So that's one thing that you could do in your area. hospital, CMEs, grand rounds, lunch and learn, any of these. Talk to your lactation consultants, because in every area has lactation conferences at least once during the year. You know, the Chicago area will have several, Rockford has one, and the St. Louis area. Wherever you are, there will be these lactation conferences. Now, it's hard to get doctors to go to lactation conferences, but if they have a really good speaker, so a physician or a PhD, somebody who's well known in their field, speaking at one of those lactation conferences, if you contact that person and say, hey, while you're in the area, would you be willing to do a grand rounds at my hospital? Usually they are, and you're going to save money because they're already traveling here anyway. So that's a great way to get outside physician speakers to come to your local hospital. And for physicians, I highly encourage everyone to look at the Academy of Breastfeeding Medicine, because this is a subspecialty the Academy is working on and making breastfeeding medicine a subspecialty for primary care, like sports medicine would be. And so they are, and this is a worldwide organization, so they are the physician experts on breastfeeding, all things breastfeeding. They have an annual meeting every year, which moves locations, but they have a pre-meeting course, what every physician needs to know about breastfeeding. That's a one-day course and goes through things I've talked about today, but in much more depth, and a lot more about the medical aspect of it. And so even if you traveled to just go to that one-day course, it would be well worth your time. But their annual meeting every year is fantastic. Join the AAP section on breastfeeding. They do a great job, and they're working on promoting breastfeeding day in and day out. And so here's your resources for medication questions. LactMed on the internet, it's through the National Institute of Health, and you can put an app on your phone for it. You can get Dr. Hale's book. He comes out with a new edition regularly, so there's a 2014 edition out, Medications in Mother's Milk. You can look up any medication in there. And there's also sections on other treatments as well. Dr. Hale started the Infant Risk Center in Texas Monday through Friday during normal business hours. You can call this number with any question that you have about what mom might be taking, because herbal things, some other things are harder to come up with answers sometimes, but anything, they will answer any question that you have at the Infant Risk Center. All right, and then here is a whole list of other resources and references that I've used and referred to and that you can use in your office. And I'm happy to, if anybody can contact me, and we are more than happy to help and answer questions that you have specifically for your office if we can, or direct you to resources to get more information. All right, and I hope we still have time for questions.
All right, hi everyone. I'm already getting some questions sent in here, so thank you for that. I'll do my best to send them over to Dr. Federici. Beth, did you get the question that I forwarded to you?
I don't know that I did, Billy.
Okay, the question was, this is a great presentation. The focus appears to be family practice and pediatrician. Will there be future presentations with a focus on OB practices? Do we know?
We do not have that in the works at this time, but we will certainly consider that for a next webinar. So thanks for that suggestion.
Okay, now I'm assigning some questions to Dr. Federici. Dr. Federici, do you see those? Under the questions tab.
I do, let's see. Are there any, okay, that's OB offices. Do they offer CMEs for CLC certifications for physicians? For CLC courses, I don't believe that they will qualify for physician continuing education credits, but what a lot of people do, you can take the CLC course and you'll have enough education credits to then apply towards your IBCLC. And I think that's a really great credential for physicians to get as well, because you can use all of your hours for patients that you see in the hospital, in the office, I mean, it can go back a good number of years, all the hours that you have contact with breastfeeding moms and babies and issues, and use those hours. So your CLC, I don't believe, is going to give you continuing education that you can use for your physician continuing education, but it's still very valuable. Are there other, that's the only question I see.
Well, Dr. Federici, the question from Teresa Berkey about are there any suggestions for specifically OB offices prenatally? That's a different question from the one that I put to Beth.
Okay, specifically for OB offices prenatally. Again, just giving information throughout pregnancy about breastfeeding. So at each visit, you can give them little sound bites of information about breastfeeding. And it's not even a bringing up, have you thought about how you're going to feed the baby? You could do it that way, but you can just start talking about breastfeeding. And then for OBs especially, because you are in the hospital right away and involved in baby friendly, you're making sure that the baby is up on the chest and getting that skin to skin right away, and being comfortable with waiting for that first feed if you can, even if you step out but step back in, watch the first feeding and see how it's going. So if there's any concerns, you can address them. And you can also be releasing tongue ties right there in the hospital. And at least in Illinois, a lot of OBs are doing the circumcisions in the hospital, so they could also be doing the tongue tie releases. I don't see why not. But prenatally, it's just providing that education and that support, so that then when she does call you afterwards, but with sore nipples, then you can also address those problems. OB-GYNs can also be seeing lactation issues in the hospital, in the office. And the other thing I should mention, especially for pediatricians, a lot of pediatricians think that they cannot see the mom because they're pediatricians, but you're a licensed physician, and there's nothing that says you cannot treat the mother. Again, it should be in the scope of practice that you are comfortable with, but if you start doing it, many pediatricians in breastfeeding medicine also see moms for breastfeeding problems. And so, OB-GYNs probably aren't going to be treating the babies as outpatients, but giving mom guidance and being familiar with baby in the latch is really helpful. Anything else?
Let's do a last call for questions here. We are a little over our 1 hour run time. Is there any last minute questions? And of course, Dr. Federici, as you say, if anyone has any questions, they can contact you directly, correct?
Correct.
And this is Beth. I would just like to thank you so much, Dr. Federici. This was fabulous, and I have so many notes that I'm going to take back to our physicians. And everybody, please keep in mind that this will be recorded, and it will be on the ICAP website. We'll send out a notification when that's on there. I would really encourage you to make this available to your physicians in your area, because I think there was just some great takeaway information in here for them on how to develop a breastfeeding and baby-friendly practice. But thank you so very much.
Thank you as well.
Thank you.
All right, thanks for joining us, everyone. We'll see you next time. Have a great day.